Assalamu alaikum warahmatullahi wabarakatuh. Welcome everyone on board. Um, we have just started our effort to just have a quick revision of anesthesia topics. So today we will just try to have some insight into neuroanesthesia. When we talk about neuroanesthesia, because neuro questions are frequently asked in the exam, and there are two different sorts these questions can be asked. One will be with reference to head injury or trauma. So if it's coming like a trauma, so in addition to all the neurophysiological and neuro cerebral concerns, there will be extra concern with reference what are there in ATLS. So ATLS alongside this head injury protocol and neck care, that will be a little different. Otherwise, the basic physiology, neurophysiology will remain the same. Okay, whether it is head injury or the other aspect which is being asked, or which we have a challenge is with reference to craniotomy for a brain tumor. Okay, so in that the concerns related to a tumor will come. Okay, so that is another aspect. Then there will be certain procedure which are rescue procedures. Some of them are with reference to head injury, like for example, extradural hematoma drainage. This is one category, or another option will be that if any bypass for intracranial pathology, like VP shunt is being done, whether it is as a protective or as a treatment of some in this in which ICP is a problem. So they can ask you as a creation of VP shunt, or you have a patient with uh, blocked VP shunt. So these are generally things which are being asked. Then one aspect is with reference to spine surgery, which maybe you can make it separately, or we can keep it in neuroanesthesia. And then there will be concerns related to because a number of surgeries like posterior fossa surgery, they are being done in sitting position. So concerns with reference to sitting position and development of this uh, air embolism. So this will be one concern you should be familiar with. And then another aspect with growing kinds of neuroanesthesia, there are certain things like neurophysiology monitoring, which is frequently being used now in a majority of good setups. So you need to know basics of what are the challenges in your anesthesia care when there is a neuromonitoring. So this is just an overview of what you can be expected when you are reading for neuroanesthesia, or you can say neurosurgery. Okay, so again, cerebral physiology, trauma, concerns related to brain tumor, and craniotomy in specific position, especially sitting sitting craniotomy, brain bleeding. And another thing which I missed actually, that baseline neurological status. So in any condition in which you are providing anesthesia care, you have to make sure that you document the preoperative or before you intervene in any way, the preoperative condition, because that will be the baseline from where you will follow that patient. And another important aspect of our anesthesia care will continue in the post-op ICU, because majority of time these patients will be ventilated or keep for as a neuroprotective strategies. So this will be part of your goals when you are preparing for it. So let's start some important points with reference to cerebral physiology. So first question, which they can ask you in a number of exams. Any exam candidate at the moment? Zishan, yes, please. Or any exam candidate who want to volunteer? Yes, Zishan, what is Monroe-Kelly doctrine? Because a
Yes,
number
sir.
of this will be a, you can say, a starter question. In simple words, how can you explain what is
Yes,
Monroe-Kelly?
sir. Sir, Monroe Kelly doctrine states uh, uh, that the CNS brain is enclosed in three parts, which includes the matter, that is brain matter, blood, and CSF. And any increase in one of the component, the other component tries to compensate it within the limited compensation happens
Like,
in these three.
in a better way, that brain is in a closed cavity. Okay. So there are, one is the brain tissue, number two is CSF, and third is
Blood.
blood. Okay. So if any of component is increasing, the other should compensate. If it does not compensate, there will be increase in ICP. Okay. So that is the basics of, like, for example, if there is vasodilatation, and or there is brain matter is increased because of some edema. Okay. So there should be compensation from the other component. If does not occur, there will be increase in ICP. Okay. So ICP is related to, like there are three things which you have to understood. What are the basics of maintenance of cerebral oxygenation and cerebral perfusion? How can you explain, Zishan?
There maintenance of cerebral oxygen, we have to maintain the hemodynamics of the patient. We have to maintain the map within the limit. We have to maintain carbon dioxide level, oxygen. We have to maintain a proper O2 levels, and we have to prevent any sympathetic stimulation or stress which can increase the rise of ICP, uh, such as pain. And so these are the components.
Actually, like, if you just make answer in a more refined way, that anything which is increasing cerebral blood flow, how can you elaborate? CO2, significant hypoxia. Okay. What else?
Sir, hyperglycemia.
Hyperglycemia will increase cerebral blood flow.
No, sir, no, not cerebral blood flow. No, no, sir, it will only increase
Hyperglycemia,
IC.
what will be the effect of hyperglycemia? Neuronal injury. It is one of the factor which will increase the chances of secondary brain injury. So I don't think so. Hyperglycemia has nothing to do with cerebral blood flow.
Sir,
Okay.
sorry, sir, map.
Yes. So cerebral blood flow is with mean arterial pressure. And actually, to be very precise, cerebral perfusion pressure.
English.
So you have to maintain the cerebral perfusion pressure. So cerebral perfusion pressure is dependent on two things. One is MAP, other is
ICP.
ICP. So they have a relationship among each other. So actually here the question was something else. Cerebral blood flow, what factor will increase the cerebral blood flow? So one will be
Sir,
hypercarbia, one will be significant hypoxia, and other will be that if the cerebral auto regulation is bypassed. What do you mean by cerebral auto regulation?
cerebral autoregulation is that the CPP, cerebral blood flow of brain is maintained within the map of 60 to 160. Uh,
Okay.
so,
And if
so
it
any
and if
any mechanism which dysregulates this autoregulation, then this mechanism is lost, and then the blood flow is directly proportional to the map.
and then another important thing will be that something which shifts it. So that is hypertension.
Shit. Chronic hypertension.
Chronic hypertension can shift it. So that will have effect on cerebral blood flow, and that will have effect on because the net result will be that there will be unwanted changes. Okay. So that's how you just correlate. So CO2 is one of the biggest factor. And one thing which is also important, because you don't want increased cerebral blood flow, but you don't want to have cerebral hypoperfusion. So these are two extremes. So another factor which can affect the perfusion is, yes, Zishan?
Sir, ventilation, sir.
No, no. This is CO2. One thing which is affecting the perfusion. So that is viscosity. This is
Viscosity.
simple fluid dynamics. If there is more viscosity, there is less perfusion. So you don't have to over correct the hemoglobin, because it will increase the viscosity. So usually the target is around 30. You don't need to increase viscosity more than that. So it will also result in secondary brain injury, because if you are talking about trauma, so primary brain injury will be there. You have to prevent all the factors which will increase a secondary brain injury. This is one thing. And if you are dealing with a patient with craniotomy, so your factor is that you don't want anything which is increasing the ICP. Okay. So, or decreasing the perfusion, or making the brain tight. Because in the exam, sorry, practically even, if like yes, you are right, hypotension is in the other way, mean arterial pressure. So that is, so, and any factor. What is the effect of temperature? Hyperthermia will,
Sir,
what will be the
increase
effect
the
of hyper? Increase
hyperthermia, I think increase the IC.
cerebral metabolic rate. Okay. So when cerebral
Yes.
metabolic rate will increase, and for example, blood flow is decreased because of cerebral perfusion pressure problem, and metabolic rate is increased, so the problem will, it can also result in, ultimately, it will result in ischemia. Okay. If the perfusion pressure is decreased and metabolic rate is increased, so there is more oxygen is required. So that will also result in ischemia. So this is the actually, I know that this is very simple thing, but if you understand this thing, it will be very easy for you to understand. Okay. So there is some relationship between these volume and pressure relationship. So, like for example, if volume is increased to some extent, the pressure will remain maintained. And then, but at some point, then there is compression. Intracranial volume, like for example, there is bleeding. So increase intracranial volume. So it is compressing the brain. So up till what time it will try to manage. If volume is increased too much, then gradually it will cause focal ischemia and then global ischemia. Okay. So this is one or another concept we should be knowing. One is Monroe-Kelly doctrine, one is this pressure, and then something related to brain compliance. When we are giving anything which is reducing the brain volume, actually, because if like volume and pressure, they are compensating each other. The brain compliance is the factor by which it is maintained. So if anything which is affecting the brain compliance, like for example, if there is edema, cerebral edema, the brain compliance will be decreased. Okay, so it's like that. So another thing, usually this is asked in the MCQs, but and actually in British or like you can say Irish exam and European diploma in anesthesia, you should be knowing these graphs very nicely, because they sometimes they ask, because whatever problem in the compliance, it will affect the Mr. Korak, can you just please don't write on the screen? Muhammad Korak, you are writing on the screen. Please, it's distracting me. Okay. So usually in our part of world, usually they are not. Mr. Korak, please, can you stop writing on the screen? Thank you. Okay. So you see, a modified arterial pressure wave that is transmitted from the large cerebral blood vessels throughout the CSF. It is usually measured via external EVD, and then there is one is pulse wave, there is one respiratory component, and then there is slow wave, which are changes in the baseline waveform, and respiratory component. whereby the baseline of waveform varies with the respiratory cycle. So these are the basic concepts. So one is percussive wave, which is P1, result of transmitted arterial pressure wave. This is P1. Okay. Then second is this wave reflects brain compliance, P2, and it's thought to occur due to the arterial waveform reflecting off the brain parenchyma. It is usually 80% of amplitude, slightly less than P1, but its amplitude varies inversely with the brain compliance. So if brain compliance will decrease, this pressure will increase. P2 ends with a dichotic notch, which coincides with the closure of aortic valve. And the third is dichotic. This wave is related to venous pressure, and thus its amplitude will increase as CVP rises. So if this is with reference to CVP. So in non-compliant brain, the amplitude of P2 increase. Okay, as they mentioned that P2 is tidal, and this is because of brain compliance. Greater than P1 with the whole waveform becoming more rounded, the baseline. So actually this just they can ask you if you should have just a rough idea about it. Similarly, this Lundberg waves, which are like one is A waves, B waves, C waves. One is plateau waves characterized by a steep rise in the baseline to more than 50 millimeter of mercury for 2 to 20 minutes. This will be the combination of these ICP waves. So if there is persistent changes, this will result in these. So B waves sharply peak rhythmic oscillations at frequency of 0.5 to 2 waves per minute. So similarly, I don't have very good concept about it. Just I read it. You can have this is physiology, physics, pharmacology, and physiology for anesthetist. So if you want, you can have few words about it. We have discussed about it. So this is also MCQ stuff, but usually you should be knowing that they can ask you this question as a starter, that how much is cerebral blood flow. So it is around 50 ml per 100 gram, okay, or around 750 ml per minute, if I'm not wrong. And then cerebral perfusion. In some books, it is written mean arterial pressure minus ICP, and some books it's written mean arterial pressure minus ICP plus CVP. Some books they have written whichever is more. So please don't confuse yourself. This is a little confusing statement. So you just, I think, because in majority of texts it's written whatsoever is more. Usually in normal scenarios, because ICP is not that much, so we usually count only CVP, because ICP usually we don't measure. So usually indirectly we can have an idea with the CVP. If CVP is too much and mean arterial pressure is decreased, cerebral perfusion pressure will decrease. So that's the main theory. And if mean arterial pressure is decreased and CVP is more, so cerebral perfusion pressure will be decreased. So that's how very simply you can estimate. Okay, and we will just have a look at what are, Zishan, can you tell me what are signs and symptoms of raised ICP?
Sir, initially, the patient will present with mild patient present diffuse uh, neuronal changes. Patient might be dizzy. Patient might have neurological neurological symptoms,
Headache,
decreased altered consciousness, headache, decreased altered
headache,
consciousness,
and
headache.
then
Uh,
Cushing's response.
then Cushing response, which is a combination of hypertension, bradycardia, and
Abnormal,
altered sensorium,
or not altered sensorium, abnormal respiration.
abnormal respiration.
Okay, so this will be a sign. There are some other sign where maybe like vomiting. It's one of the sign of raised ICP. So you can have, you should be knowing what are the usual signs. Okay, so that's what I was.
Papilledoma is also.
Yes, papilledema is also. Yes, you are right. Okay. So, like usually clinically it will be headache. So then another important point they can ask you, actually these graphs why I'm showing, because in the Western exam they usually ask. In our exam even they can ask rarely, and they can ask you to draw the graph, but usually you should just have an idea what of this. That for example in this way side there is pressure, okay, and this is the blood flow. So if you have blood pressure between 60 to 160, the blood flow is maintained. Okay. So blood flow is 50, as we mentioned, 50 per 100 gram per minute, 50 ml per 100 gram per minute. So this is, you see, stable. Okay. But If it goes beyond, pressure is going beyond this limit. If it is below, the blood flow will decrease. If it is more, the blood flow will increase. So that is the concept of this graph. In this range, it is maintained between 60 to 160. And when it is going in crossing or in chronic hypertension, the graph is shifted, as they have mentioned here. From the left side, it is shifted to the right. So at higher blood pressure, the blood flow is maintained. So now, for example, what is the interpretation? That you have a chronic hypertensive patient and you maintain the blood pressure at 50, okay, or even 60, not sorry 50, 60. So now the 60 is causing decreased blood flow. So that is the concept. When there is decreased cerebral blood flow, the decreased perfusion, and patient can have ischemia. So this is the fact. Then the second thing about CO2, gradually it increases horizontally, like sorry, proportionately it increase, okay, but at the time there is plateau on there. That's what happen in chronic hypercapnia. So if chronic hypercapnia occur, there will be like there will be a plateau. So uh, so that is uh, what is shown in this graph. Then O2. So up to 60 millimeter of mercury, or here 7.5 kPa, okay, there will be maintenance. You see, you can, it is maintaining on 50. So, okay. But if hypoxia crosses this limit, suddenly the blood flow will increase. Okay. So when blood flow will increase, it will cause uh, decreased cerebral perfusion. So this is the concept. This is another graph. So then these are some more point about oxygen consumption through 3.5 ml per 100 gram of these are more of actually MCQs. And this graph is with reference to cerebral blood flow and cerebral metabolic rate. So because this is important to understand for inhalational agents and IV agents. And this is with temperature. So increase in temperature, increase cerebral metabolic rate. Okay. And moderate hypothermia, it actually decreases the cerebral metabolic rate. And it is one of the factor which we are using for uh, like uh, post arrest care. So we just create a mild to moderate hypothermia so that the metabolic oxygen requirement is decreased and cell may regrow. Like this is the concept that you are just trying to prevent the secondary brain injury. Okay, so in this graph, they have just explained a little bit about the blood flow and cerebral metabolic rate. So cerebral blood flow is increased with all these stuff, okay, and cerebral blood flow is decreased with all these stuff. And this is with reference to cerebral metabolic rate. So usually in this direction, cerebral this ketamine and nitric oxide can increase cerebral metabolic rate, okay, and cerebral metabolic rate is decreased by these things and also somehow by inhalational agents. And that's why isoflurane is considered to because it is causing luxury perfusion. That's the concept of luxury perfusion you are getting with isoflurane, uh, because it increases the blood flow and decreases the cerebral metabolic rate. So this is just few words about it. They say it less than when concentration 1 point are reached, then cerebral autocoagulation is abolished. So these are some points you can be asked. Okay. So they can ask you about, actually, this is again a question which is being asked in the Western exam. Usually they are not asking in our exam, but now since it's there, so we can have few words that it's produced by the choroid plexus of lateral ventricle, foramen Monro, third ventricle, Sylvian duct, fourth ventricle, and then Magendie or Lashka, spinal canal, and absorbed by the arachnoid villi in venous sinuses. It's very simple. You know, this book is a wonderful book for revision, and like it's very simple. So, choroid plexus, foramen Monro, through foramen Monro enter third ventricle, from Sylvian duct enter fourth ventricle, and from fourth ventricle, from these two foramen of Magendie or Lashka, go to spinal canal and then reabsorption. So let's have few words more, then we will go to the practical aspects. Actually, this is the basis, what we have, whatever we have discussed. Believe me, that is what all our neuroanesthesia is. Now just convert it into craniotomy. Only few things will increase. But like for example, the how to control the ICP. So we will just have few words that we have to control the factors. Like whatever we are doing, we are trying to maintain the CO2. We are trying to avoid the stress response. We are avoiding because dura till the dura is open, that is a painful step. After that, that painful step is gone. Usually it's not responding much. And then if the surgeon is saying tight brain, same mechanisms will be applied. You will give what will be the steps for tight brain? Yes, Zishan. How will you
Sir,
manage
we
the
will,
surgeon?
sir,
Yes.
we will, sir, we will maintain normovolemia, normocarbia,
No, no, just a
normotension.
second. Again, your approach will be airway breathing circulation, 100% oxygen.
Yes, sir.
Okay. And then you will try to look for the causes what you can improve. You will make sure there is no factor which is, uh, you will just check it out and then you will go try to correct whatever is there. Now you can tell what you were saying. Normovolemia, normotension, normothermia, normocarbia, normoxia, adequate analgesia. When all the correctable things you have corrected, what will be your target for CO2?
Sir, between 35 to 40
No.
mmHg.
Where did you read this thing?
Sir, I think 4 to 4.5 kPa or something like this, sir.
No, no, no.
30 to
Please,
30.
Zishan, this is not a good answer.
Yes,
Please try to improve.
Low
And what
normal
you have,
side,
please speak out, Zishan Abdurrahman.
सर लो नॉर्मल साइड पे कह सकते हैं कि लो नॉर्मल साइड पे
No, 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 no. I should have a stick from where I wish to hit you, guy, both of you. I'm not happy. Abdurrahman, think and answer. Is it the answer? I'm sending a dollar for you, both of you. It's it's it should be around 33 to 35. What? N-tidal or PaCO2?
एंटाइडल पे
No. What is difference between N-tidal CO2 and PaCO2?
sir, usually there is a difference of 5 mmHg, sir.
So which is more?
Sir,
Hmm.
PaCO2 is more, sir.
PaCO2 is more.
Why PaCO2 is more and N-tidal CO2 is less? Why?
Sir, because there is a dilution of CO2 when it is monitored in capno, sir.
Okay, because of dead space.
Dead
Dead
space,
space.
sir. Dead.
Okay, so usually, if anything, increasing the dead space, this difference may be more. So whenever we are using this word 33 to 35, this is PaCO2. Okay, so for that, you just need to monitor both. Like whenever you are doing ABG, you have to look at the number, the amount, the number in the end-tidal CO2. And then when it comes back, you just compare. And just you can make with one or two ABGs, you can have accuracy that in this patient and this settings, what is the difference? So if it is 5, for example, so you will try to monitor around 28 to 31, like that. So this should be very accurate. And O2, it should be more than 60 millimeter of mercury. Okay. And similarly, viscosity, not more than 30. Temperature, like you should avoid hypothermia as well as both severe hypothermia and severe hyperthermia. You should try to maintain normothermia or towards slightly towards mild hypothermia. Okay. Then what else? That if you all cover these factors, what will be the next step? You have to look into it. Yes,
We
both.
can,
Yes.
sir, we
सर
can
एंड
look for the pharmacological therapies.
You have told the wrong answer. Zishan, you try. What will be the next step?
The next step, we can deepen the anesthesia, provide adequate analgesia to the patient, and
Mm, this
provide
is
any
where the
stress factor.
stress. What do you mean by deepen the anesthesia?
Sir, we can matlab, light pain, maybe patient light plane of anesthesia can also stress, induce
So you
stress,
will
which can.
increase the MAC,
No, sir, we can give IV. We can increase the
the
IV
TIVA,
induction agents. TIVA,
TIVA,
yes, sir.
not induction agent. You know, it doesn't look good. You are making a maintenance. You are saying induction agent. Does it look good, Zishan?
No, sir.
So why you are saying the wrong words? Please. Okay. So you will increase the
Yes.
TIVA. For example, if you are giving total intravenous anesthesia, you will increase. You are missing again the same mistake what Abdur Rahman was doing. You are doing the same mistake. Look into it. Try to see. You will make slightly head up. Other factors. Think about it. Then you will make sure the endotracheal tube is not tied very tightly. Is it important?
Yes, sir.
Okay.
Yes, sir.
And here, meaningfully, how will you monitor the depth? Because you have said that we are not looking much into the MAC. Even maybe you are not using in the
Sir,
neurophysiology.
we can use the
Whenever we are
BIS.
very good, BIS entropy. Okay. So you will make sure you have adequate BIS level. So how much is the target for BIS?
Sir, 40
Sir,
to 60.
40 to 60,
40
sir.
to 60. Okay. And actually, we will just now we have reached up to here. So now you can think about some points with reference to neurophysiology. They are monitoring what aspects they are monitoring. The neuro actually in good setups there is special neurophysiology person who is monitoring. So what things that they are monitoring? One is this BIS or entropy, and actually they are doing the proper EEG. The full channel, how many channels? I forgot the number. There is a specific that much channel EEG. So one thing they are measuring is EEG. What else?
That's somatosensory work potential.
Somatosensory evok potential. Number one, number two, number three.
Sir, brainstem auditory work potential.
Motor evok potential.
जी.
Then brainstem auditory evok potential. Visual evok potential. Okay.
Continuous
So
electromyography monitoring of seventh nerve.
this
Yeah.
is MAP. This is monitor this motor evok potential. Then their target is that you should not give bolus. Okay, you should give infusions. So what are options for TIVA? Propofol, remifentanil, fentanyl, dexmedetomidine. Okay, lidocaine infusion. So these are some. You can have a combination. Okay, you can have a good amount of opiates, and you can have something like that. So your purpose is to maintain, and one is TIVA, and preferably you can have you will I will try to cover these few points, but you should know that if possible, you can say if possible, there are special pumps which are TCI. They are target control infusion. There are few words which should be knowing that the mechanism is that it is working on the three compartment model, and it is making sure the blood levels are maintained. If you are want to increase the depth, initially they will automatically give a required bolus, and then they will increase the maintenance to the certain level so that the drug level in the blood will remain the same. And there is demographic data with reference to age, sex, height, weight. Okay. And there are specific models for some of the medication, like fentanyl is there, remifentanil is there, and propofol is there. I don't remember exactly this topic. Schneider model, Marsh model. There are some limitations of it. There is a special good article on target control infusion. Please do read about it. Whatever I remember, I can recall, I have told. This is some basic points which they can, if you even if you know up till that one, maybe you will pass, because this is the concept of target control infusion. Because whenever they are measuring the neurophysiology, they don't want any change. If you give bolus, it is bad for them. Okay. So and then you have to knock out the patient because you are not giving muscle relaxants even. Okay. So So if you are not giving muscle relaxant, so you have to make sure you have steady state. And then another practical important point will be that you have to make sure your IV line is working, because you have a CVP, you have arterial line. So try practically, this is another practically, that usually the TIVA line, it's better to keep it in the foot so that it's in front of you, and you can see any swelling or any change, because there are case reports in which it's going extravasated or the line is blocked, there is going air, there are so many things. If you have attached it in the proximal side with the heads are tugged, if you have attached to CVP, even then it is difficult to monitor. So always better to take an IV line in the foot and give it to TIVA through that, so that you have access. And even later on, before you finish, or if you want to extubate the patient, if you want to see the neurological status, it will be easier for you to manipulate if the patient IV line from which you are giving is nearer to you. So that is the concept of this thing. Okay. So when all these things fail, then you will come to what you were saying, mannitol, and what else?
Hypertonic saline.
Hypertonic.
Furosemide, hypertonic saline. How many times you have used hypertonic saline? Why you are saying for the first? Usually, usually mannitol is the most common one. How much is the dose of mannitol?
Sir,
Oh, 0.25 to 1
0.25
gram
to 0.5 1 gram per kg.
0.5 to
gram
1.5. What? Milligram per kg?
per kg.
Gram per kg. Gram per kg, sir.
Gram per kg. Okay. And usually it is how much percent it is? 20%.
20%.
Maybe different percentages are available. So whatever percent it is, usually it is 20%. Maybe it's different available for so whatever you have to calculate, like it is 200 milligram per ml. So you will calculate. So one gram will be 5 ml. So you will calculate like that. So for example, if you are giving, you have to give 100 gram. Okay. So 100 gram for 5 ml is 1 gram. Okay. So you will give around 200 ml. Sorry, 500 ml.
500.
Okay. So like that, you should have like, and what will be the mechanism? It's a heavy
Osmotic
material.
diuresis.
Osmotic
Os-
diuresis. How? It's a heavy molecule. It's
Yes,
bringing
sir.
the fluid with it.
Sir,
It will
ये water
increase.
full करना है.
Yeah, it will pull out the water from the intracellular space to the extracellular space. And what will be the problem? It can occur if you have a patient with low ejection fraction, weak heart. It can
Pulmonary
cause
edema.
pulmonary
Yes,
edema,
sir.
Can go into pulmonary edema.
because initially it will cause hypervolemia and then it will cause hypovolemia. So that's, you should understand. And sometimes after giving mannitol, after some time, there will be a lot of urine coming. Okay. So you have to be careful about these things, and you have to monitor the fluid status accordingly. So if you have attached through the cardiac output monitor, or even if you have just attached a arterial line with a mechanism like Massimo, for example, it is giving you indirect values by which you can see that whether the patient is going hypovolemic or not. Okay. So this is something which you should be knowing about mannitol. Mannitol also has some free radical scavenger system. So this is how you will be monitoring. So coming back, some same theoretical thing. But usually these are the mechanism, and believe me, the same thing is there. Mannitol you are giving for head injury. Mannitol you are giving for right brain. Something extra which we use for um, CA, like sorry, brain tumor induced raised ICP. One medication else, which we have not discussed yet. What is that medication? Thiopentone is not too
Dexamethasone.
very good. Dexamethasone. Thiopentone is coming in the TIVA. You can say that if you need, and actually the thiopentone is usually used for as a barbiturate comma in improving the outcome after cardiac arrest. Okay. But dexamethasone is being given to reduce the edema in tumors, not in head injury. Head injury, it has bad outcome. Okay. So again, the same thing. What is this? Okay. So this is, I think, Hagen-Poislet.
Yes,
Okay.
sir.
Hagen-Poiseuille. So this is dependent on this thing, and how that's why this viscosity is increased, blood flow will decrease, because this has inverse relationship. And this delta P is cerebral perfusion pressure, R is the radius of the blood vessel, and the length of the tube, that is blood vessel. So that length and radius is not that much important here. The more important thing is here viscosity. So if you increase the viscosity, the blood flow will decrease. Okay, so that's another thing they can ask you, how will you monitor? So radius, how it will be affecting by cerebral metabolism, carbon dioxide and oxygen, autoregulation, neurohumoral factors. So we have discussed actually these things. And actually this is up till now, whatever we have discussed is the basics of neurohumoral, what they have written here. A major difference between other systemic circulation and cerebral circulation, lack of humoral or autonomic control on normal cerebral vascular tone. Like there is vasoconstriction in the body, but it is not doing vasoconstriction in the brain. Okay. The parasympathetic nerves contribute to vasodilatation, may play a part in hypotension and reperfusion injury. For example, after cardiac arrest. Blood viscosity. Yes, this is also MCQ step, but you should be knowing for 7% increase, sorry, it's a decrease in by each 1 degree centigrade fall in temperature. Okay. And by 20 degrees centigrade, the cerebral about 10% reduction is the factor that allows patient to withstand prolonged periods of reduced cerebral blood flow without ischemic damage for uh, after during even cardiopulmonary bypass. They are putting this uh, ice. And one more thing that they do in cardiac surgery, if you just because this word has come, so I'm explaining. In cardiac surgery, that's why it's very important. Okay, because this will be one factor that they maintain the temperature. But another thing is that they always do carotid Doppler or cardiac CT to see what
5 मिनट है
is
तुम्हारे
there
पास.
is there any if there is any baseline decrease in cerebral blood flow. So that is the thing which you should be not be forgetting. Okay. Just a second, please. See again, my hand slipped. Okay, so what will be the extra points about craniotomy? Okay, so if you are just thinking about craniotomy, usually there will be one craniotomy which is posterior fossa surgery, simple craniotomy. Okay, so in preoperative assessment, you have to document the baseline neurological status, and now comes the neurological thing which can occur. There may be some sensory or motor loss. There may be fits, like there may be some cranial nerve involvement. So you just have to document about it. Okay. So if there is whenever the word seizures come, the anti-epileptics come. So what are the effects of anti-epileptics on anesthesia?
सर एंजाइम इंड्यूसर्स हैं तो जो हमारा क्रॉस रिएक्शन होता है
Only
कैपिटल्स के साथ.
only enzyme inducers. Anything
सर
else,
इनका
Zishan?
ब्लड
तो
डिस्क्रेजियाज,
बाकी
थ्रोम्बोसाइटोपिनिया,
Then
सर कार्बोमेज़ापिन also cause electrolyte abnormalities,
you are missing something very simple. Liver functions.
liver function.
So liver function and bone marrow. So bone marrow, liver, these are two important thing. And third, what we are saying, electrolyte imbalance. So you have to look into it, because all medications which we are using are metabolized through the liver, and if they are creating problem, it will then you have to use uh, the things which are avoiding any stress response. So now we will just have because now it has come, so we can how what are the concerns in managing the airway, either in head injury or in craniotomy or any neuro patient. Just a second. Other than Zishan and Abdurrahman, anyone else want to speak out? Sadaf, are you also exam candidate? Waqar, you are also exam candidate. That's what I know. Anyone else speak out? Only two people are speaking. Not interested?
Yes, sir.
Yes.
Dr. Syed Muhammad Ali.
Yes, yes. So what are the concerns in managing the patient with head injury, either or craniotomy? Just think about it and tell me, please. Some of the things are
Okay,
common and some of the things are extra. So first discuss head injury.
okay, sir. In the head injury, first of all, we will think about all these things which we've.
I'm sorry, by mistake I make you mute. Please unmute. I'm sorry again. Please unmute yourself.
No, no problem, sir. No problem.
Yes.
Sir, basically in these patients is we are suspecting the patient is already having increase in ICP due to any reason. You said about that patient is on trauma or head injury. So we will try to induce the patient all these by keeping all these factors which we already discussed, that by taking positioning, by counseling the patient, and by inducing such way that without increasing the stress of religious stress, and also making the patient pain free before the induction.
Muhammad Ali, you are missing something very important, and you have told a big story, but you have not told the main point. If you don't know, then I
Uh,
will give chance to Sadaf. You have missed
Sir,
something very
in head,
important. Yes, yes, Sadaf, please continue.
sir, in head injury, first of all, important thing is the initial examination of the patient, and considering in the mind the other injuries of the cervical spine, and holding the head of the patient with care, and clearing the oral airway.
Listen,
These things are to
Sadaf.
be done.
Sadaf, I'm really sorry. You all are again the same mistake which I expect from you guys who are reading the books. I have asked what question I have asked. What care or what things are important for managing a patient with head injury with reference to airway? You are just trying to reproduce some page of the book. Think the answer is
Excuse me, sir, can I
few
speak?
words answer. You have to do the neck care. You have to do the manual inline stabilization. You have to use a technique in which you are not because you cannot rule out neck injury. Am I right? Yes, Sadaf?
yes, sir.
So what long story you
Yes,
are
sir.
telling? You don't need to tell these long story. To be very specific, you have to do the neck care. The neck care will be there. Okay. So what neck care you have to do? One of them is, how will you tell?
Sir, manual inline stabilization technique or
Okay.
two-hand technique.
What else? You will keep the, because a number of time there is neck collar.
Yes.
Okay. And then what airway devices you can use?
Video laryngoscopes and
Video
CMAP.
laryngoscope, glidoscope, which has acute angle. So you don't need to
Yes.
manipulate the neck
Yes.
too much. You are not overextending or over flexing the neck. Okay. So that is what is your aim. You are not overextending the neck. Okay. And another thing is that you don't want to have cuffing. Okay. Because cuff will increase the ICP. Okay. Then another thing which it has come, so I will tell you here. Would you like to give PEEP in ventilation, or you should avoid it? What
Sir,
has
if there is high risk of venous air embolism, then
mm,
it has some role.
PEEP
Otherwise, it
PEEP
increases.
with reference to ICP?
Sir, it increases ICP.
So then you should not use it. Okay. Try to avoid
Yes, sir.
extra PEEP because it can increase the. Of course, if risk versus benefit, if there is compelling indication to do to PEEP, that's something else. Otherwise, it's better not to give too much PEEP. Okay. So that's something important, and you might need to have this one fiber optic if it's some indication of, because you don't have to manipulate the neck too much. You have to avoid all the factors which are causing increase in cerebral, as all of you are telling, but you can use in minimum words, because exam, you don't have time. Like Muhammad Ali Shah and Sadaf, both of you were telling the right thing, but extra you were telling too many things which are not required. Okay. And then another important thing will be Inna lillahi wa inna ilaihi rajiun. I forgot what I was saying. Yes, because the patient will be at risk of aspiration as well. So would you like to use suxamethonium? Yes or no?
No,
Yes.
sir.
Sorry. Yes, Sadaf,
Sir,
what you were saying?
if I have rocuronium, then I will avoid the suxamethonium.
Suxamethonium. What is the effect of suxamethonium on ICP?
Sir, it will transiently increase the ICP.
How?
बेटा चुप करो मैं पढ़
How it increase?
Hmm.
Due to fasciculation?
Yes, due to fasciculations, intense muscular contractions. Okay.
Hmm. That's what- Okay.
So that's how you will try to avoid it. It will also increase ICP and F. Why it's very dangerous? Because if there is in head injury, you don't know what's the dynamics. It can cause even coning of the brain. Am I right? The ICP is why we are worried about ICP. ICP, even normally we are coughing and our ICP is erased. Our wife is fighting with us and our ICP is raised, or vice versa. Your husband is fighting with you, your ICP, but we don't have coning all the time. But it head injury, the normal anatomy or a normal physiology is gone. So now, even if there is sudden change in ICP, it can cause even coning, and coning can cause sudden death. It can cause even sudden death. So that's why, you don't correlate the things. If you correlate the things, then you will understand, then you will never forget. And now you can say, if you still have to use suxamethonium, you don't have rocuronium, you have difficult intubation, you are afraid, if there is risk of aspiration, then what you will do? You will do risk versus benefit. And is there way you can decrease the fasciculations with suxamethonium? Quick, please.
Yes, sir. We can pre-chlorize the before giving the suxamethonium.
What is difference between pre-chloralization and priming? This is just a revision of the thing. What is difference between pre-chloralization and priming? What is priming?
Um, Priming is, sir, when we want to give the atracurium, and if it and for one third dose before giving the atracurium, we can prime the receptors so that we can decrease the onset of action of atracurium. And
Very good. You
pre-chloralization
can
is
just improve your answer, fine tune, make it a beautiful word before giving the full dose of non-depolarizing muscle relaxant. We give a small dose, maybe 1/5 to 1/10 dose, so that some of the receptors are preoccupied. And when we are giving the induction agent, after that, when we are giving the subsequent dose, the duration of action uh, will be faster, and you will have the intubating condition in less time. Now, does it look good,
yes, sir. Yes, sir.
or you are using only atracurium? Does it look good?
Okay. Okay.
Okay.
Non-depolarizing muscle.
Remember one thing: exam is just an art. Okay. Of course, behind that you will have a science. But again and again I point you out. Please try to not to reproduce the pages of book. Yes, Abdurrahman, what you want to ask?
Sir, I have a question regarding RSI doing sucks and
Yes.
recuronium. If
Yes.
we are suspecting there is high risk of aspiration and patient has raised ICP, isn't sucks the better choice regarding securing the airway because of lower time to
You know,
onset of
you
action?
you are absolutely right. That's why we are saying that it's both techniques can be used with risk versus benefit. If you are using suxamethonium, transient ICP can be raised. You can have something to reduce the ICP. You can give a dose of mannitol. Okay, you can use a technique which to do some precuriorization. You can just say, things should be in your hand. Don't use closed-ended sentence. Don't say that even in difficult airway you have risk of aspiration and you are saying that I will not give suxamethonium at all. It's a haram. No. Say that if you give suxamethonium, you have this problem. If you are giving rocuronium, you have this problem. So be diplomatic. The diplomatic answer will be the most correct one. Okay? Agreed, Zishan, Sadaf, everyone?
Yes, sir.
Okay. So, with reference to monitoring, if you are saying that in addition to standard 1 and standard 2 monitoring, in this scenario, what you will be using, just tell me one thing, is urine output in standard monitoring?
No, sir.
No, sir.
No. So urine output, okay. Then arterial blood pressure, cardiac output if it is there. What else monitoring you can tell? One is neuromonitoring, of course, neurophysiology monitoring. You can say about T. Of course, this will be an extended answer, but if you have a high risk of embolism, then you can say, because the most accurate way of monitoring air embolism is T. Okay. This is another thing you can tell. Then actually another thing which is there in the exam in the good setups, that they do navigation. Okay, before starting the surgery they do the navigation, and the purpose of it is a surgical thing, but I'm just telling you that in neurosurgery they are do navigation. By navigation they are actually just trying to get the accurate angles. Okay, so that's why when they start the anesthesia and before the NCN, there is a lot of time lag behind. So in that time, actually, the patient can have significant drop in blood pressure if you have maintaining, you are not able to maintain. So in that time, you are actually trying to have the point, and then suddenly after navigation and every neurophysiology, they are putting all over the body, they are putting the pins. So you have to put the this one bite block. You have to put the bite block because they are monitoring the facial nerve, they are monitoring the orbicularis oculi muscle. So they are putting the pins for neurophysiology, they are putting the pins all over the body. So that's something you need to know. And then after all navigation and neurophysiology and everything, suddenly they are doing the pinning. So pinning will have a significant effect on the anesthesia requirement. So even maybe you have given us a starting dose of muscle relaxant, and now when we are doing the pinning, patient can have sudden swings of blood pressure. It can badly affect ICP. So before pinning, you have to make sure that you have adequate depth of anesthesia, you have an adequate, and is there anything which you can do for pinning?
Sir, ये
Hmm,
scalp block ये
Very
जो
good.
we
है
can apply
So
the blocks.
you can have a scalp block. So in then extra question which I don't remember, but you should be knowing what are the nerves blocked in scalp block. I don't remember it, and it's something all cramming stuff. But you can have a look here. We will just this is actually an article about it. Here you can find uh, the nerve supraorbital, supratracheal, zygomaticotemporal, auriculotemporal, greater occipital, lesser occipital. So these are the nerves which they can ask you. This can be asked in the MCQ exam as well, and then practically because if you don't remember the nerves, it's better not to tell. Okay, or like you should be telling very scientifically. Like if you remember it, it will create a very good impression. Okay, say that so that's why there are very small things which you should be knowing. Okay, then before you start you should be knowing, if you we have few words about tumor. So tumor, of course, there may be in some, usually they are not giving it, but maybe sometime you have to think about it. Radiotherapy, chemotherapy, any hormones, maybe patient is taking any hormones, and if it is a secreting tumor or it's a non-secreting tumor. So you should be knowing about pituitary tumors. You should be knowing about pituitary tumors. So you should be knowing what are different pituitary tumors and what are their effect. So there, if it is like growth hormone related, so it is maybe acromegaly. Okay, if it is anything like gynecological, so maybe things related to gynecological symptoms and risk of DVT and things like that will come. So hypertension in so endocrine effects of the pituitary tumors, we will try to have a look at it, but I'm just telling you. So that will be one thing. Any baseline neurological problem, how much it is extended, which area of brain it is involving. Okay, are you able to extubate the patient at the end of the surgery or not? Okay, so these all things you should be knowing when you are dealing with a patient with the tumor. And then of course you should be knowing where they have to give the this one where they have to give the NCN. And then one few words more, that if they are not doing, because a number of surgeries they are doing the neurophysiology now, okay, but if they are not doing neurophysiology, there are still cerebral oxygen monitoring. Okay, so I will just try to show you few words about that one. As there is one O3 monitor, and then there is another monitor, I don't remember the name. So you should know few words about that. So okay, intro neuro monitoring. These rest of the things are the same. Remifentanil, you are using normothermia, normoglycemia, BIS levels. We have already discussed a number of things. Mannitol we have discussed. PEEP may increase ICP. We have discussed about it. Venous air embolism, alhamdulillah, we have discussed in our complication, big topic. But still, you should be knowing how to manage it. You will attach with the CVP another separate syringe for the aspiration of, and where you should attach. There are three ports. You should be attaching to the proximal one or the distal one.
So distal one.
Why distal one? Because when you have to aspirate, it should be the distal one from where you will aspirate the air. If you will attach to the proximal one, the medication which you are giving will come here first. Okay, so it's always preferable to be attached to the distal one. So okay, so these are the things which you should be knowing, and the same factors which you are doing in the intraoperative period, the same factors you have to monitor in the post-operative period. Okay, so we will discuss few words about in the posterior fossa surgery. It is sitting, and then because the vital centers are there, so there are more chances of like post-operative ventilation. There may be more neurological damage, the chances, okay, more bleeding, and concerns in sitting position, uh, the more chances of venous air embolism. There will be atypical position. How will you do the CPR in this position if it happens? So this is also something a very challenging thing. Okay, so rest of the things actually are same. Pneumocephalus, like air is entering in the cavity, icteric complication. So during surgery, various techniques may be used to reduce the volume of brain, which encourages air to enter the intracranial space. And when the cranial cavity is closed, the brain expands, the air is compressed, causing a mass effect with elevated ICP. So pneumocephalus is one of the complications. So you should be knowing how to identify. Maybe CT scan is cleared recovery. You need to do the CT scan. High flow oxygen reduces pneumocephalus, but in cases you need to open it again. You don't need to do you need to do the Burhal, and of course surgical. Macroglossia, obstruction in the to the venous and lymphatic drainage of tongue because of flexed neck during prolonged surgery in sitting position. So this is another thing. Quadriplegia, because the spinal cord can be damaged. So because it's near to the this brain stem and then spinal cord. So posterior fossa surgery in that way, it is important. Okay, so routine monitoring we have, invasive arterial blood pressure monitoring we have, and yes, important thing I forgot to mention, that in neurosurgery you should zero the arterial waveform at the level of tragus, okay, not at the level of heart, because it will give you more accurate reflection of cerebral perfusion. Okay, so you will zero transducer should be a slightly higher. Okay, so this is another important point.
Yes, sir. Circus of Villas is at that point.
Yes, that's it. And another thing is that it has to go against the gravity, na? So if it's sitting position, especially, it should be important. So air embolism things we have discussed before. New monitoring. Okay. So some words
सर ये
actually
इसमें
this.
थोड़ा सा ऊपर है इसी में था सर
Okay. I hope you are getting some concept. And again, up till now, whatever we have revised, that you remember one thing, that the basic concepts are the same. Same oxygen, same carbon dioxide, same temperature, same viscosity, same glycemic control, use of mannitol, use of positioning, airway management, and few things now we will discuss. Like patient is being taken to CT scan. So you are as a trauma, so ATLS approach will be there, advanced trauma life support, and then you have to do the manual inline stabilization. The airway management will be challenging, so you have to make sure you are doing the techniques which are avoiding secondary brain injury. Okay, so you should not raise any reason for increase in ICP. You should try to prevent aspiration as well. And then you can say that we can have arterial blood pressure monitoring, so that you can monitor the beat to beat. So these are the things where you can tell. And then they will take the patient to CT scan, and then they will decide if it is any midline shift or anything. They will take the patient for CT scan. Sorry, for burr hole or EV drain, or removal of subdural hematoma. Okay, so that will be sort of emergency procedure. That's some of the real emergency procedure in which you need to react immediately. Okay, so because otherwise it will cause neurological damage. We will just few words. We will have I have actually downloaded one presentation. Let me show you just a second, please.
Sir, would it be fair to say that in every neurosurgery case, our goals of anesthesia would be 99% similar?
Same, yes. That's why I'm telling you, it's very easy. Neuroanesthesia is one of the most easy topic if you understand. It's very easy. Okay? It's
Sir,
very easy.
if we say that like our goal is to maintain IC, to our goal in anesthesia is to avoid significant rises in ICP, maintain
Yes,
cerebral perfusion pressure, allow neurological monitoring, and
yes,
early detection and management of complications.
very good. Like, Abdurrahman, I leave it on you. Believe me, you can make in your own words. But what we use in our language, kam kharch bala nashi. Use compact words. Don't do in Saudi Arabia, in Arab, we can say mafi girgir. No girgir. So the answer which you people guys usually do is girgir. Why? It is scratching the brain of the examiner. They just want you to tell in minimum words, and you are telling a long story. Like the story, I'm sorry, I'm not just to bring some smile. Like the story when we reach home and our wife started telling us. Okay, so try to be very compact. The few words, if you are using few words, that will be more effective. So make your own words. I have told I am, because these are the very simple thing which you have to do. If you understand, then it becomes very easy. Okay, so now we will have few words about this a number of things. I just found this very good presentation, so I will try to explain whatever I can through it. Just a second, please. Okay, so there is fall, gunshot wound, motor vehicle accidents. Also, one thing is GCS. There is another way why we monitor is AVPU. Okay, either GCS or AVPU. Okay, and if the patient is very irritable, so then you can say about if you are have given sedation to any patient, so then it is Ramsay scale. If you have a patient very aggressive, so then you can say RAS, Richmond agitation sedation scale. Okay, and I think another one for delirium, CAM ICU. So okay, so there will be scalp injuries, penetrating injury, epidural hematoma, subdural hematoma, subarachnoid hemorrhage. Only few things we will come to it, that only one hemorrhage is a little different, which is subarachnoid hemorrhage. So in subarachnoid hemorrhage, there is a concept of cerebral vasospasm. Okay, because blood is there inside the subarachnoid space where the vessels are there. Okay, so if there is development of cerebral vasospasm. So which medication is being used for prevention of cerebral vasospasm?
Amlodipine. Sorry,
Nimodipine,
sorry, Nicardipine.
Nimotop. Yes, so it's a calcium channel blocker. Okay, because if there is cerebral vasospasm, there will be uh, decreased perfusion of the brain. Then another thing which is part of it, we will just try to have some word about it. There is a grading scale, Hunt and Hess classification for subarachnoid hemorrhage. It's a very stupid thing to remember, but you have to remember. So Hunt and Hess, and I think there is a GCS classification, something like that. So you should be knowing how to classify subarachnoid hemorrhage, and then the preceding factor will be aneurysm. So if there is a cerebral aneurysm, you have to prevent the rupture. So for rupture, you have to avoid hypertension. Okay. If you have significant hypertension, there will be more chances of rupture of cerebral aneurysm. But if it ruptures, then you have to maintain the blood pressure. So that was the concept of triple H therapy. Now actually concept have changed, so they don't do hypervolemia, but still they need to have hemodilution and slightly higher blood pressure, higher normal. Because if they have the low blood pressure, it can cause cerebral anoxia and ischemia. The same, but the remember one thing, when you are telling this triple H therapy, tell that the same base is the same. You have to maintain the cerebral perfusion pressure. That's why you don't avoid to have hemoconcentration, because if hemoconcentration, the blood flow will be hampered. If you have hypovolemia, the blood will there will be less chances of. So you are maintaining the volume. You don't let it go down, and slightly towards the higher side if it is permitted. So that's how you can explain your answer. Rest of the things are the same again. So subarachnoid hemorrhage, these few things you should be knowing how to classify subarachnoid hemorrhage. Hunter has classification. I will try to show if we have time, but this is the how. In any head injury, anything, you don't forget primary injury has been done. You have to avoid all the factors which will cause secondary brain injury. So this is, you should never forget. Okay. It is MDCT. I don't know what is MDCT. Then a few words about what they are doing. Let me show you. CT, yeah, they can ask you a question. I will show you in another head injury as well. That if there is any symptoms, headache, vomiting, age, intoxicated, there is amnesia, there are seizures, and there are change in conscious level. Okay. So, resultant loss of consciousness, GCS, either it is low on presentation or there is significant fall. Okay. So that's the reason for you should be doing CT scan. Okay. I will show you for these thing a little different. I think they have explained in a different way. Here I wanted to show you something else. So skull fracture can occur, and here you should be knowing either it is combination, because as I told you that here you should be knowing all the factors with reference to ATLS. But few things, few names you should be knowing. One of them is CSF rhinorrhea, this battle sign, raccoon eyes, okay, and then hemorrhages, intracerebral hemorrhages. So this is battle sign, okay, mastoid ecchymosis, raccoon eyes. and this is sign of base skull fracture. Okay, and I'm not going in too much details because this is beyond our scope. Yes, this is what they can ask you. Default fracture is actually in major maxillofacial, and you should be knowing. I never remember it. I'm sorry. I can never explain. I never understand this thing. How to horizontal fracture through the maxilla that involves a piriform fracture. I am so lucky that I don't have to remember it again. So I am skipping it actually, but you should be knowing how to explain it. Leaford fracture one, two, three. Maybe you can explain, understand with the picture. I'm really sorry to. I think this is one in which this part and two going like this. I'm sorry. I wrote no. I know only this thing that in two and three you cannot do uh, nasal intubation. Am I right? And three, you need to do the tracheostomy. Anyone knows about Leaford fractures? Yes, Abdurrahman,
No, sir.
but read about it.
Uh, Sir,
Yes.
I have remembered three things that the Leaford one is basically maxilla is involved only mainly. That is why
Okay.
we can do nasal, but they're difficult to do oral intubation. These
Okay.
two with maxilla, there is also the side cheekbones is also involved, just like a nasal septum involved. So we
Mhm.
cannot do nasal intubation, but slightly can try depending upon the situation oral. And Leaford 3 is basically our lower plate or eye ball is also involved. So that is most extensive and can cause the base of skull injury also. That is
Yes.
something uh,
So
mota
you
mota.
need to do tracheostomy.
Yes, sir. Yes, sir.
So actually, this is also a very nice word. The floating palate, floating maxilla, floating face. I'm sorry. I'm a very open person, which I don't understand. I am sorry. If Lefort's fracture someone understand, they are the real gem of people. I never understand this uh, Lefort fracture. Anyways, so okay, so depressed fracture like this, mm, ping pong skull fracture, so something going in and outward. Okay, resembles a ping pong ball that has been indented inwards with a finger. Okay, we will have, so it's like that. Elevated fracture if it is coming up. Okay, temporal bone. I will show you something. Overlies a why worried? Overlies a dural venous sinus. It can bleed suddenly. Overlies a middle meningeal artery and oblique cortex, which is related to sensory motor cortex. Depressed, stable with. Just a second. Measles and penetrating here. Another topic actually they can ask you. I will try to show you this. That is one counter co injury. So counter co simple words is that in which damage located both at the site of impact and on the opposite side. Counter co is a whole topic. So here impact and then where it is exiting. So there is one on the impact and one in the opposite side. So epidural hematoma. It's like biconvex. Okay. So they can ask you in actually in talks. Um, our badge, they asked, I did not have very good grip on radiology. So somehow I don't know what I answered at that time, but it was asked to us. So you see, it's biconvex like that. So in epidural hematoma, there is a lucid interval. There may be a headache. Lucid interval that usually conscious level is improved before deteriorating. Okay, so it's like that. Yes. So why EDS do not cross the sagittal suture lines? Because there are some flexions of the dura mater going. Okay, so falx cerebri, which runs along the sagittal suture, which at the base is fixed, so cannot be crossed from right to left. So this is one of the factor to identify between epidural and this one subdural hematoma, because in subdural hematoma they can cross. Again, just a second. Yes. See, in subdural, it's like that. Okay. So collection of blood between dura and arachnoid, and it is crescent shaped, extraaxial, may cross sutures, not dural attachments. So this is they can ask you, even if you know these few one or two points, you can explain to them if it's being asked in even in your talks. Usually, of course, this is not our domain actually, but we should know some basics, especially if someone is working in ICU. They have to be very good in it. Unfortunately, because in Saudi Arabia, I'm not working in ICU at all. So, and this is my weak point, unfortunately. So, one is traumatic subarachnoid hemorrhage, and one is related to subarachnoid, this hypertensive or cerebral aneurysm. So, yes, another important point topic which I will just show you. I think that's just wanted to show you. These are extra things. Anyways, okay. So, few things. One is interventional radiology. So, what are anesthesia concerns in interventional radiology? This is a topic which they can ask you in the exam.
Sir, one our concern would be related to out of operation theater anesthesia.
Very good.
Patient access will be limited.
Mhm.
Monitoring will be difficult, and
Okay.
uh,
Actually,
other
one of them, this is one out of OR. So one point, other point will be that maybe it is diagnostic or curative, or maybe head injury. Okay. Because these patients are also coming for carotid stenting even. They are doing the carotid stenting just like we do in the cath. So interventional neuroradiology is now totally developed specialty. Number of things they are coming for clipping, cerebral aneurysm clipping. Okay. Or they are taking the patient for uh, only diagnostic. Okay. So it may be diagnostic or it may be therapeutic. So uh, therapeutic for how, what thing? See, endovascular treatment of cerebral aneurysm, AV malformations. Okay. Then preoperative embolization of cerebral and spinal tumors, if they want to decrease the size. Embolization for epistaxis. So you should read this article, at least few words about it, so that and actually now we see all these cases, sclerotherapy for venous angiomas. Even sometimes they are in the face also. So they are doing under interventional radiology. They are doing balloon angioplasty of carotid stenosis and vasospasm, as I told you. Okay. Intraarterial chemotherapy for tumors. They are doing it. Treatment of acute thromboembolic stroke. The patient has a stroke. They take the patient directly according to the protocol. There is a thing about it, and they do uh, the management. So that's how. So the basic things will be the same. Only few things you need to tell. Okay, same neurological assessment will be there. The same factors which we have discussed will be there. Out of OR concerns will be there. Tricky situation. Sometime actually they are doing under local. They are doing under monitored anesthesia care. But any complication can occur, and you need to manage the airway at that time. There are so many problems. Another important thing is that you cannot make the heads because it's a straight table. If you any one of you have worked in cath lab or anything, so radiological concerns are there, or radiation occupational health problems will be there. because there are a lot of radiations, and then the table is very straight. So you have very limited access. You cannot manipulate the position of the patient. Okay. So this is additional thing you should be thinking. So all same concerns which are there in any neurosurgery, some of them extra I have explained to you. Okay. Mm, investigations, ECG, according to the scenario. If it is hypertensive, so you have to you can tell about any microvascular and macrovascular complications of hypertension. Okay. Similarly, subarachnoid hemorrhage. This WF, World Federation of Neurosurgical and Grading Scale of subarachnoid hemorrhage. Remote site anesthesia, radiation safety, patient access, equipment monitoring. Okay. So you will be able to answer anticoagulation. Okay. So because in some time they are giving heparins, and they are giving some all even thrombolytic therapies. At some time they might need to give. So that patient is at risk of subsequent stroke as well. Okay. So these are the things. So maintenance, you can say hemodynamic stability, hemodynamic stability, maintenance of cerebral perfusion pressure, patient immobility. If you are doing even in monitored anesthesia care, you might need to give some sedation, and if you give some sedation, now you have opened a Pandora's box. Okay. Sometimes even if you have gone nothing, maybe patient is listening to you. But if you have touched, you have given something, now things are out of your control. So if you have any doubt, it's better to maintain the airway and give GA, because if in between it occurs, then it's a more challenging thing. Okay, maybe surgeon is at a critical step and patient suddenly move. What will you do? So if in the exam they are asking you that it's a challenging thing, so it's better to maintain the airway whenever it's needed. So that's it. Okay, so perform an ETT to LMA exchange or awake patient. Yes, another thing there, that if you want to avoid the stress response, a number of times, this is another technique, that you remove the endotracheal tube and you put LMA. A number of times it's being used. Even I have seen some of the consult when I was assistant consultant. I don't like personally. Okay, but actually I have seen sometimes they change it with LMA and then they gradually extubate. I never do it. I don't like it actually, but I have seen people doing it. So aneurysm perforation, intracranial vessel injury, there may be strokes. So yes, contrast. So another important thing you don't forget, contrast induced anaphylaxis, contrast induced nephropathy. So you are in intervention radiology or any vascular procedures or anything where, so think about anticoagulation, think about contrast induced problems. So what are the medications or what are the things you should be thinking about contrast induced things? Yes, anyone please?
Sir, urographin.
No, this is
Most
for them. What for you?
And adequate volume loading and
Very good.
N-acetylcysteine.
N-acetylcysteine. Okay. So N-acetylcysteine is, you can
Okay.
say, what is it? If someone asks you, what is it? Very good. जेड़ा बोले वही बुआ खोले. Okay, you are saying something and you don't know. This is a crime. Okay. So actually,
Antidote of
what is the role? What is the use of N-acetylcysteine in ICU? Can anyone tell?
it's sir antidote of paracetamol
acute
poisoning.
liver injury. सर acute liver injury में use होता है.
You are all of you. Again, I am sending all for you. All of you, I am sending Dala. Okay.
secretions kit.
Sorry. You are
Sir,
telling
it
where. How many times you have used for paracetamol poisoning? How many patients you have seen for paracetamol? Now, my statement is you are using in almost every patient N-acetylcysteine. Can you prove me wrong?
Yes, sir.
No, you cannot prove me wrong. Please think about it. Yes, Sundas.
sir, viscosity of secretions,
Yes,
something.
mucolator type होता है.
Yes,
Yes,
it's
liquid
mucolator sachet. We do it for nebulization as well as we are putting in NG tube to
Yes.
thin out the secretions. Okay. So as mucolator, it's being used frequently. N-acetylcysteine, when we are giving for paracetamol poisoning, it's something very hi-fi. How many, if we have 20 people right now, how many people have seen it even for this thing? Okay. So don't tell uncommon things, tell you very simple things. Even if you have, if you ask, they have asked you about contrast induced problem. So simple, any contrast or anything external, there may be anaphylaxis. So one thing is anaphylaxis, number one. Number two, because it can cause renal dysfunction. So maintenance of blood pressure, maintenance of volemia. This is very important. Before you telling N-acetylcysteine, please do tell these things. It will not create a good impression if you immediately say N-acetylcysteine without telling the common things. You will make sure the patient does not have any allergy. You have to make sure patient is having good volume before they are giving. So it's like that. Okay. So, okay. Great, Sri. So actually you have a look at it. Stereotactic surgery, I think like awake craniotomy. I don't have very good concept about this stereotactic surgery. What is stereotactic surgery? I think it is awake craniotomy. Hmm, Anyways, do anyone knows about stereotactic surgery? Anyways, so another question they can ask you about VP shunt. Okay, so VP shunt creation or VP shunt block VP shunt. So in block VP shunt, there may be patient with the what is the name of the disease in which there is high ICP? I forgot, slipped out of my mind.
Hydrocephalus.
Hydrocephalus. Okay. So sometime there is congenital hydrocephalus or anything they are putting shunting. So there will be concerns related to pediatric anesthesia. You have to tell like that. Okay. And then it's a very painful when they are putting through, if they are creating it, when they are passing through the skin towards the abdomen, it's a very painful step. So it's like you have to give adequate anesthesia at that time. Until the time it's not developed, you have to make sure the ICP is managed. And another thing, if it is blocked, it's like a critical emergency. Because if the VP shunt is blocked and you don't secure, make it, because in VP shunt, either if the time is permitting, they will put a new one or they will try to canalize the old one. But in emergency, they might need to do EVD, okay, or burr hole just to relieve the pressure. And then they will put they will reconstruct or whatever recanalization. So the basic thing you should be knowing that the rest of the things are the same. There is nothing special about VP shunt. Okay, but you should be knowing what is the concept. So I think we have covered almost majority concepts and majority things about uh, neuroanesthesia. So you can see here this uh, Hunton Hess classification and World Federation Society, this uh, classification. Nimotipine is being used, epilepsy. How will you monitor, how will you manage the epilepsy? Usually they are giving the dose before, like a number of times this Keppra is being given before the surgery. Otherwise, if the patient is on anti-epileptic medications, you have to make sure there is adequate levels. So in elective procedures, you should tell that if possible, you have to maintain the drug levels. And this is the same care which is required for any patient on anti-epileptics. So you have to anticipate the complication related to epilepsy. You can have a fit. So you will try to avoid anything which is increasing the chances of fits. So like any precipitant factor, then among the induction agent, thiopentone is the best anti-epileptic. Okay, propofol can be used, but the best one is this one. And then you avoid if it is a prolonged surgery, you try to avoid atracurium because atracurium has so-called product like inosine which can cause epilepsy. This is actually practically, I don't know whether it happens or not, but in the exam, maybe they want to listen from you this thing. Okay. Another topic, I'm sorry, I'm not very good at it, is I'm trying to close my eyes like a pigeon. But I think before we finish, I will try to have few words about it. I don't like it, but they can ask you in the exam. Awake craniotomy. Okay. So actually, it's a technique in which they won't have communication with the patient. Okay. So there are certain reasons they are being done for resistant epilepsy, and there are some other reasons for it. Okay. So they are doing scalp block. One of them is this thing, and then they give a special like dexmedetomidine is a good choice because it gives a good control, but at any point of time, patient can have any neurological sequence. So patient need to be to maintain the airway, or you need to give anesthesia, or sometime they make the patient sleep and then awake and then sleep. This is another technique. Okay. So pardon me for my lack of knowledge for this topic. I hate this topic, but I need to tell few words about it. There are certain reason, you see, these are the things which you can remember. One thing, if they ask you this question, the basic thing will be the same. Only few things here I did not find the indications of awake craniotomy. You should know the indication. I'm not able to find. Yes, this is the space
Understand areas of space
eloquent area. I don't understand what is this eloquent area. I'm sorry. I don't never understand what is this. What do you mean by eloquent area?
sir, which is area which is used for fine motor skills and fine speech, like a musician, the uh, like the
So
motor movement on which musician depends upon. We can say
yes.
that is
Okay. So actually the thing which I remember minimum words is that you all the cerebral physiology things will be there. Scalp block, don't forget. Reasons for indications that there are some anatomical reason, pharmacological reason, epilepsy, and some physiology stimulation or lean generation of deep brain nuclei, subthalamic nuclei, increase undertaken for intractable movement disorders like Parkinson's disease, okay, or dystonias. So there is a specific should be knowing the reasons, the contraindications, okay, and challenges you can have: confused patient, communication difficulty, extreme anxiety. Patient can have fits. Patient, like these are the challenges which you can have intraoperatively. So pardon me for please. I again say that I don't like this topic. I don't have much experience about this topic. But by the way, this question came in our Irish fellowship exam, and somehow I had crammed this topic at that time. And I have written, I remember I have written this in the exam. Okay. They have given you, so in this last 1.5 hour almost, I have tried to cover you the main concerns, main things about neuroanesthesia. Okay. In spine, extra thing will be prone position. Okay. So now I will ask you one question, that if you have a surgery going on in prone position and your tube is dislodged, what will you do?
sir. In this situation, first we should have already a plan in place.
Hmm?
We should have identified and we should have given responsibilities for this type of emergency.
Okay.
So everyone should understand that if we can either, if the condition allows, we can either move the patient and intubate
Abdurrahman, you are
them.
missing something very simple again. This is because, in the exam, why I tell you again and again, because this will have in the key, call for help. Immediately inform the surgeon. My approach will be airway, breathing, circulation. So this never forget to tell. Okay. And now what you can do, you have pointed out a very nice statement that whenever you are doing any surgery in the prone position, you should always have a plan that in case the tube is, first of all, you will try to avoid, you should have a very good fixation about the circuit, about the tube and everything. But you should have a plan that in case cardiac arrest occurs or endotracheal tube is dislodged, how to manage. Okay. But now, when you are telling, you tell this statement, now practically what you will do, call for help, airway breathe. So you will try to ventilate through the mask. You will sit, you will take a chair, or you will try to ventilate with the mask. And now you should have a backup plan. Few options you will have. One option is that you can try to put an eye gel or LMA. Okay, this is one option. Another option will be fiber optic. Another option will be that if possible, you will try to turn the patient straight to intubate. So there are multiple options you can tell. Okay. So similarly, the next part of question, this question was asked in our Irish fellowship exam. No, not to me, to my friend. I was in another batch. So this question was asked in the morning. And we had no idea about this topic, believe me. So it was very lucky for the people. I was not in them, and I actually, maybe I was not able to answer, but our friends answered. Some of them give us very simple answer for it. And for example, the next step was, part of the question was that you are not able to give oxygenation properly and your patient has a cardiac arrest. What will you do?
Sir, start CPR on prone position.
Will it be
Back.
successful?
Then I think it would be successful. And then try to, as soon as possible, shift the patient into spine position.
Okay, so actually the problem will be that actually the special table is like this, okay? Not the table which we use. Actually, there is a gap in it, okay? So abdomen is hanging through it. So it's very difficult to flip the patient. And actually the another, it's called actually Jackson spinal table. So there is a hole through which the abdomen is hanging. So it's very difficult to actually sweep the patient. So actually so you will try to do from behind, but if everything fails, as a last resort, because the spine is already open, the surgeon will open the thorax and try to have open cardiac massage. Maybe they want to listen this answer in addition to what you have told, that you will try to flip the patient, you will try to make the patient straight, that's it. Okay. So of course, and you should pray that it never happens, because we always, so many times we are doing this surgery in prone position, but it's very difficult to handle. It's something we can only pray that it does not happen to us. Okay. So any comments? I hope it gave you some idea. So Monroe-Kelly doctrine, cerebral blood flow, oxygen, CO2, temperature, inhalational agents, IV agents, opioids, vasodilators, vasoconstrictors, what will their effect? Positioning, okay, cerebral blood flow, steel phenomena. I have tried to cover a number of concerns about it. And again, remember that neuroanesthesia is something which they will always ask. Neuroanesthesia or head injury. It's not possible that both of these things not come. It is almost paper out. So whether they will ask you subarachnoid hemorrhage, whether they will ask you posterior fossa surgery, whether they will ask you, yes, one thing additional, that in this pituitary surgery, just a second, pituitary surgery, because they are doing it transnasal. Okay, so transfenidal pituitary surgery. So the rest of the things will be the same. You should be knowing, as I discussed before, that you should be knowing the effects of the individual hormones and individual tumors. Okay, so I think I will stop here. I hope you got some benefit out of the discussion. Okay, and Tomorrow we will have a session on liver. Okay.
Okay, sir. Thank you so much.
Thank you, sir.
And Sundas and Sayyid Muhammad Ali Shah, because you have not attended much of the classes. Abdurrahman and Zishan, especially, they have been tuned a lot because I have scolded them a number of times for their approach. So I will request the same to you. In the exam, they don't want you to speak something from the book, especially. They want the practical conduct of anesthesia or the words in a way that correlate with each other. Okay. Like you should not try to, because books, they are written in one dimension. Okay. In exam, you think practically and try to, even if you have to reproduce a page of the book, don't think logically what you should be doing the first, what should be the second thing, what should be the third thing, and try to use minimum words. As I explained to you, no girgir, no extra words. And please, again, I request you, because some questions, they are so common, so I think it's always better that you create a answer prehand, as Abdurrahman was pointing out in between, that you can make an answer which is covering all the common. Even you can tell about the position, you can tell about swings of blood pressure which occur at the any steps. Even you can tell about fluid, you can tell about analgesia, you can tell about neurophysiology, you can tell about all the factors which is affecting the cerebral perfusion or intracranial pressure or things like that. Okay. I will tell you, most probably the same time as today, because it gives me a more time. Or if not this time, then at 10 o'clock, 10:30 Pakistan time. So anytime I will tell you. So please keep in touch. If any one of you is not in our WhatsApp group, just message me on WhatsApp, and I will add you, because I sent the message on the Facebook as well. So when any one of you is, if they are not in our WhatsApp group, they can join us on our WhatsApp group. And I am just a message away. If you have any question, any comments, anything you want, please feel free. And thanks to all of you who have pulled out their time and give us honors. Thank you very much. Assalamu alaikum.